So we have three speakers for you today. We have Professor Bo Oppenheim, we have Professor Jordan Freitas, and then we also have one of our LMU alum, Marina Marmolejo, who will be speaking to you. So we'll start with Professor Oppenheim.
Thank you. A few slides about a new domain of knowledge called healthcare systems engineering. We have a graduate program, master's level, here at LMU. It's a brand new thing, very important for healthcare. So first, let's see. I cannot see slides from here. So in the left column, we see the desired characteristics of healthcare. It should be affordable, accessible, safe, effective, patient-centered, timely, efficient, and well-integrated in all dimensions. And we all know that it's anything but that in the United States. On some scales, we fare better than on others. For example, timely, yes. In the US, we typically don't wait very long for tests for specialists. But on other scales, we fare poorly. Specifically, what I want to discuss are those topics here: imperfect access, imperfect equity, fragmentation, which is a huge problem, providers burnout, another huge problem, and then electronic medical records. So, starting with imperfect access. The present administration caused 10 million people approximately to be moved away from Obamacare. In other words, they lost insurance. And the very conservative statistics, very conservative, are that there is 500 deaths per 1 million uninsured. Altogether, we now have 27 million uninsured nationally, 3 million in California. So just a simple multiplication gives us 13,500 people dying every year because of the lack of access. Okay, that's a serious number. And that's an avoidable number. That's the worst part about it. The cost of US healthcare, you probably know it, is 3 times higher than the next country, and that's the UK. Medicines are unaffordable to 100 million people. 100 million people have to decide if they buy medicines or if they pay rent. And 1/3 of US adult population skip recommended test or treatment because of cost. Those are horrendous numbers, horrendous numbers. Let's talk about fragmentation. Imagine the following situation. It's quite routine that, I feel a pain in the side of my body. I go to a doctor. The doctor is not sure what it is, so sends me to take a blood test and then perhaps an imaging test and maybe sends me to a specialist. So in the left column, in yellow, see the number of all the stakeholders involved in this process. There is the patient, primary care provider, specialist, perhaps a few nurses are involved, clinical laboratory, imaging laboratory, pharmacy, electronic health record, and if it's a more serious case, the hospital. So we list in systems engineering, we list the stakeholders as rows and as columns, and thus we get what's called an n-squared matrix. In this case, it's 9 by 9, a matrix of 81 interfaces between various stakeholders. And each box here represents an opportunity for a dropped ball, for fragmentation, for information, critical information about the patient, not getting from one place to another place, and people die because of that. As a result, in this box on the right, up at the top, we see that we have up to 400,000 people dying from avoidable death. The primary cause is fragmentation of care. So it's equivalent to two jumbo jets crashing every day. Okay, when a jumbo jet crashes once every 5 years, the media never stop writing about it. We have 2 of those daily. Okay, that's a serious number. Imagine standing in the middle of this raging river. Okay, how do we feel? That's exactly how doctors and nurses feel. That river is a river of patients, a raging river of patients. They have only 15 minutes for a clinic visit, routine visit, a little bit longer for geriatric or pediatric or first visit, but the routine is 15 minutes. And they don't have enough time to close the charts, electronic charts, to enter all the information into the computer. So they do it after hours at home very often, and they answer patients' emails at home. And those folks are seriously burnt out. And the typical situation is that a doctor lies in bed after a full day and goes like this mentally, okay, you know what? God damn it, in that second patient, I forgot to examine this. I forgot to ask this question. I forgot to prescribe such and such test. And it all accumulates. That stress accumulates. So providers' burnout is a huge problem. The causes of burnouts: fragmentation, lack of control, bureaucracy, tremendous bureaucracy in healthcare. Frustrating electronic medical records, not enough time to close the charts until late at night, not enough time to reply to emails until late at night. And the symptoms of burnout are exhaustion, medical errors, sleeplessness, suicidal ideation, and actual suicides, drug use, depression, family breakdown. Burnout, if you ask a typical medical doctor now, what's the most serious problem? They are likely to list 2 or 3. One is fragmentation, one is burnout, one is the horrible electronic records. And that's, in fact, what I want to move to, the electronic medical records. So electronic records clearly are a vast improvement, but they are so imperfect. They steal so much time from medical doctors. Presently, we have, for all practical purpose, 2 major software called Epic and Cerner. They were developed for billing. They are billing-centric, not patient-centric, not provider-centric. The main complaints from providers, from doctors and nurses, is lack of operability. I go to New York, I'm hit by a bus, okay, I'm unconscious, they take me to an ED, give me a shot of adrenaline to revive me, I die because I happen to be allergic to adrenaline, okay? And they have no way of knowing it. Unless if it happens in Southern California, yes. If it happens anywhere else, no. We are the only country which does not assure interoperability across the country. In Europe, they have interoperability across all of Europe, okay? We are way behind on this point. Not congruent with medical workflows. Each medical specialty has its own workflows. We do this, and then we do that, and then we do that. Those electronic records are not compliant enough. Verbose notes, difficult to write, many mistakes, errors, difficult to extract useful information by another doctor. Poor feedback from clinical tests. Very often a signal goes to the electronic medical records that this test was positive, this patient is ill, okay, needs help. And that message is not flashed as an alarm to the doctor, and the doctor sees hundreds of tests coming back to him or her and does not notice that one should be listed in red color as an alarm situation, those kind of problems. Difficulty extracting rounding sheets for rounds in hospitals. So presently residents spend hours and hours before rounds copying by hand from each screen some number to a paper, and then next screen to the paper, next screen to the paper for one patient. Then they move on to the next patient, and they repeat the process. Okay, it takes hours, and errors, of course, are made in the process. So very, very lousy system. And also bureaucracy, it's all time consuming. So electronic medical records are listed as the 3rd reason for frustrations and for the burnout. We don't have very much time, so I'll cover this slide only conceptually. There is an ongoing work for improving medical records. We at LMU are involved in a major project that involves Kaiser Permanente at the top level and UCLA Health IT manager at the top level, and there is a lady from Veterans Admin. So maybe we'll get lucky and improve the process a little bit. Healthcare systems engineering is this body of knowledge which we bring to the rescue of healthcare, including all of the problems that I described and many, many more. It started in 2014 with this report, famous report coming from the White House called the PCAST report by the Presidential Council on science and technology. And that report appealed to systems engineers to come to the rescue of healthcare. Immediately, we initiated a contact with Kaiser Permanente. Kaiser Permanente was enthusiastic about working with us, and together we developed our program. It's now a primary program of this kind in the US at the master's level. Kaiser provided fantastic national level experts as instructors. We also have instructors from MIT, from UCLA Health, from Stanford and others. Kaiser is starting now a new school of medicine. You probably know it, and it's a no tuition school of medicine, free tuition. It's an amazing thing. And they selected us for the dual degree, medical degree and Master of Science in Healthcare Systems Engineering. So that was a very big compliment, recognition. And this point is interesting, that the best Chinese university, Tsinghua, in Beijing, copied our program, adopted, the better word is adopted our program verbatim starting next year. So we have some objective measures, that we are doing good. Let me differentiate very quickly. This is I have only 2 more slides. Between the body of knowledge called Master of Business Administration in healthcare, Master of Public Health, and our healthcare systems engineering. So those guys are primarily focused on finance and management of resources. Those guys primarily are focused on national level issues such as environmental health, infectious diseases. They are now very busy with this new coronavirus coming from China, women's health, and so on. National level issues, serious issues, national level. We, in contrast, deal with problems in hospitals and clinics focused on operations, focused on a typical problem, maybe shorten the discharge time of a patient from the hospital to a skilled nursing facility. So we are focused on operations, and our program involves, besides some basics in systems engineering and project management, we put a lot of emphasis on integration of the fragmented pieces, on lean streamlining of operations, on patient safety systems and quality systems, IT, medical devices. We don't teach how to design medical devices. We teach how to integrate medical devices into the overall care. Population health, that's outsourcing the care into the patient's home. For example, diabetic patients are treated as a group by emails, by mass information campaigns. In extreme cases, a nurse may even go to a patient's home from Kaiser and seeing a very obese patient, with a sugar level of 350, glucose level, and sitting there eating from a bucket of ice cream. So that nurse may go to the patient, sir, what would you rather have? Amputation and blindness? Okay, or may I take this bucket of ice cream away from you? So they even go to that level of intervention. But basically, population health is dealing with large populations of patients all at once. And big data analytics. So that's the scope of our program. Let me summarize. There are very serious issues in healthcare, in US healthcare. Most problems in operations can be addressed and solved and helped by healthcare systems engineering, including lean. There is an immense need for this body of knowledge. We do not tell the doctors and nurses how to do their job. We free them to have more time with the patients. And our comprehensive master's program in healthcare systems engineering was developed with Kaiser Permanente. It truly is a high caliber program directly addressing the industry needs. And if anybody is interested in the program, I would be more than delighted to talk to you. Okay, thanks so much.
Thank you, Professor Oppenheim. We now have Professor Freitas, who's a computer scientist.
Yeah, my name is Jordan Freitas. I'm an assistant professor in computer science, and I have some perspective on these issues in healthcare because I used to work for an electronic health record system, and I also taught health informatics classes at University of San Francisco. So what I want to overview now is both what precisely are computer scientists doing in healthcare and what can go wrong when we fail to acknowledge and wrestle some of these ethical challenges. So Professor Oppenheim did a great job of explaining electronic health records. Computer scientists are knee-deep in the software issues, and we care a lot about getting those things right. We touch everything from the activity of data input to the format of it. We design features like alerts and reminders and all these things like that. We also design the system of accessing these record systems, so who has access to what. It's not like everyone has an account and the software looks the same. It's like, as a patient, I want to see my data. As a doctor, I want to see my patient's data, things like that. Computer scientists develop and design consumer health apps and devices. These can be great for facilitating and promoting personal health goals and well-being. We also work on data analysis tools and developing machine learning algorithms to take this health data and push forward advancements and innovations in health and medicine. There's also computer scientists working on biotechnology, but I'm not one of them, so I won't make any moral judgments about their work, at least not today. So now I want to get into some of our ethical challenges with the electronic health records specifically. We, as computer scientists working on this software system, we shape the patient-provider interactions. So I've heard an analogy that in the cockpit of an airplane, it's taken great care is taken to make sure that a new feature introducing some complexity and potential distraction is worth it. So we don't necessarily think about doctors' offices in the same way, even though a doctor typing notes into a computer might make a patient less comfortable telling their intimate details of their stories. And then there's also the issue where the doctor is potentially distracted, and it's not flying an airplane, but it is, a source of potential misunderstanding in misdiagnosis and things like that. That can be a life or death situation as well. So the access control mechanisms in the medical record systems determine, like I said, who has access to what. There's all these different stakeholders who care about the data. It's not just the doctors and the patients. It's researchers, funding agencies, billing. Then there's the question of, as a doctor, should they have access to all patient data or just their own patient's data? Should they always have access to patient data or only when they're in a, patient-provider encounter, things like that? We have to design the system to answer those questions, hopefully in partnership with healthcare providers. Professor Oppenheim also talked about interoperability and what can go so wrongly if we don't do this well. And then the medical record systems also have clinical decision support systems built in, and I'll talk about that a little bit more in a bit. But basically, software-assisted decision-making in terms of the treatment and prescriptions prescribed to patients. So with the consumer health apps and devices, a lot of time, any computer scientist can develop an application and stick it on the app stores for download. These apps have access to all kinds of data on our phones, and those can be exploitative in nature. So maybe my fitness tracker doesn't actually need my call records, right? But there is no, at least right now, opting in and out of specific permissions and data. If I want to use that app, then I need to, it's all or nothing in terms of what I allow that app to access. So it's computer scientists who we hope are conscious about not exploiting these permissions. Consumer health apps and devices are less regulated than those in the point of care. So there was an app a while ago that you took a picture of some issue on your skin and it would suggest whether or not you should seek medical attention. And if that kind of app is not regulated, then we have no sense of the false positives or false negatives. What if it says, oh, you don't need to go to the doctor when actually you do? What if this isn't going to be a perfect app, right? So what happens when it goes wrong, and how are we catching those cases, if at all? So there's that. A lot of these apps and devices also have kind of built-in, if it's just kind of like lone computer scientists, developing and deploying these, then they can make problematic assumptions that perpetuate misinformation and negative stereotypes and exclude minorities. So for example, an early iteration of the Fitbit period tracking only allowed you to enter 10 days worth of bleeding in a month, and after that you had to delete your data or just not keep track of it. And that is not reflective of the experiences of many women, and it just wasn't built into the way the app is used. So that's just one example. Then there's the data analysis and machine learning algorithms. There's two sources of bias in this process. The first is that when the data is collected, two things can happen. There's choices and value judgments made in what data we collect or not. We're literally saying this information counts, this information does not count, and that is subjective. There's also been studies that show that doctors, even well-meaning doctors, prescribe less pain medication to women and minorities to women and people of color who describe the same amount of pain. So there's a bias there, and the algorithms that we're developing are looking at past diagnoses and prescriptions and to determine what should be prescribed next given some sample case. So this bias is now codified into the algorithms that we're using to support the clinical process, and that's a problem. A few days ago, last week, there was a report published that a health record company had actually taken payments from drug makers to prescribe more addictive pain medicines. So just by virtue of this automated treatment plan existing, it can be exploited. So what happened was the doctor would see an alert and they would be prompted to ask the patient about their pain. And then the software would suggest maybe some referral to a specialist or physical therapy or some kind of medication. And the software company accepted payments from the pharmaceutical company to more often and specifically target patients who were prescribed less profitable drugs to more addictive, more profitable opioids. So yikes. One contribution of computer science in this conversation also is that there's no such thing as de-identified data. What that means is that even a lot of my colleagues in health informatics are this data set is de-identified and therefore I will share it widely and we will learn from it communally. That sounds great in theory, but by the time enough information has been removed so that it is adequately anonymized, it is no longer useful data. And we're also sharing a very much more simplified version of the data that was collected to do this analysis, which is problematic because we're simplifying complex medical issues. Finally, there's the question of informed consent. So ethics boards require that when you're collecting and using data for research from vulnerable people, that you take extra precaution in getting their consent to opt in to be part of that. And by definition, patients are vulnerable because they depend on the system. And if we're asking for their consent to opt into our tools and research data analysis, then when are we asking them that question, and are they informed about it while they're preoccupied with getting well? One of the most important ethical questions, I think, for computer scientists is the technology that we're developing exacerbating inequality, or is it potentially reducing disparities in the system? So liberation theology tells us to constantly ask, how is the work I'm doing relevant to the suffering of the poor and the relief of that suffering? This is tricky because in health technology, there's a temptation to see the opportunity to relieve global health suffering, like global poverty, is on another level than it is in our day-to-day life, probably working in this field right here. So there's a temptation to get in on that, per se, to do meaningful work in that space. But I'll just share an example. So my research group was invited to work on patient identification in a hospital in Haiti. They had been printing identification cards, but it was getting too expensive because they expected to print everyone a medical identification card, and then the rate at which people were losing them or sharing them turned out to be more expensive than they could maintain. So our research group was invited to weigh in on how we could offer a technological solution that could simplify and expedite and make that whole process cheaper. So we thought about it, and we suggested voice recognition. So fingerprinting is a little bit problematic. They said that it was difficult for them to implement that for different reasons, so we suggested voice recognition. Voice recognition is not good for identifying someone's identity, but it is good for verifying identity, just by the way that that technology works. And in response to that suggestion, the people who work at this hospital sent us back one picture of the waiting room and the line, and it was really clear just from this one picture that like a voice system is not going to work in a crowded hospital waiting room system. So that's something that like I was involved in personally, but this is also happening all the time. The Gates Foundation a few years ago invested like $23 million in a telemedicine project in India, and then after 3 years, it was like had very, very low adoption rates and almost no impact. So all this money was spent, kiosks were deployed, and for what? So all that to say that this is a complicated question. Liberation theology also tells us to incorporate and prioritize the perspectives of those who experience injustice. So when we're asking ourselves, like, how do we navigate this work? This is important to keep in mind. It's also important to note that progress is not inherently relevant to the poor if a new cure or a new insight is only accessible to the very privileged. It also reminds us that, or liberation theology tells us that the rich get richer not only while the poor get poorer, but at the expense of the poor. So as computer scientists, the other thing I propose asking ourselves is, are we facilitating, are we contributing to the systems that perpetuate the rich getting richer at the expense of the poor? So that's my perspective. Thank you.
And now our last speaker will be Marina Marmolejo, who's an alum of LMU. And then afterwards, we'll open up for questions.
Cool, thank you. I am actually gonna throw up our website so that there's some sort of visual that we can look at while I'm chatting to you all. Cool. So as Dr. Tarleton mentioned, my name is Marina Marmolejo, and I graduated from the Health and Human Sciences Department very recently, actually, in 2017. And promptly after, I attended Yale University to get my master's in public health, which leads me here today as the founder and executive director of an app called DreamKit, which is for at-risk marginalized populations, specifically young people experiencing homelessness. And so my journey to homelessness advocacy, homelessness research, really started at LMU, which makes me so happy to be back sharing that with all of you. It actually originated from a class that Dr. Tarleton taught called Health and Wellbeing in Homeless Populations. And so I took that my sophomore year, and it was a really holistic approach at trying to understand the mass craziness that is homelessness. And so Dr. Tarleton taught it from the perspective of health, right? So what does health look like in terms of physical health, musculoskeletal health, mental health, nutrition, right, when you don't have a house and you're sleeping in shelters and drop-in centers. And it was really interesting because she put very specific examples to what this mass problem looks like. So for example, if you have diabetes or hypertension and you're going to drop-in centers and soup kitchens and all they have is really salty pasta and leftover pastries, like that, you can't eat that. And therefore that will lead to like malnutrition, you're experiencing food insecurity at the same time. And so there are these very complex issues that we were able to break down and talk about in the course. And then conversely, the class was taught by two professors, so Dr. Tarleton and then Dr. Tim Huffman, taught us from like a community health policy perspective. And so what does it look like when hospitals are deinstitutionalized and all of their patients are being let out to then experience homelessness? Like on the streets in Skid Row, in Venice Beach, we see them and we're not talking about upstream factors. So to say that class was overwhelming is is an understatement. Like it was so much information all at once. We're talking about homelessness and like I said, food insecurity, violence, substance use disorders, racism, right? Like Black and brown bodies experience homelessness at higher rates than their white counterparts. So when I'm getting all this information, I don't necessarily know what to do with it, right? Like little Marina, sophomore, feeling pretty overwhelmed. And to the cherry on top was that course was actually a lecture and a lab. So yes, the lecture was overwhelming, but the lab piece was something that changed my life forever. We attempted as a cohort to experience homelessness during our spring break, so for 4 days and 3 nights in downtown and Skid Row. So what that looked like is going to soup kitchens, shelters, drop-in centers, and living as if we were experiencing homelessness. And so I went in kind of weirdly excited to put myself in this uncomfortable position and learn and grow. But the pushback that we received from people who were actually experiencing homelessness was really extreme. They saw us as university students who had all this power and privilege, and they felt like we were treating their life like a game, and they felt like we were making fun of their experience. And so having that feedback, in addition to other folks who were really excited that we were there and happy that we were able to live how they live, at least for a short amount of time. And so exiting that experience, I felt very conflicted about the negative feedback and the positive feedback that we received. But overall, that made me realize that there's so much more to learn and to uncover and to research that among populations experiencing homelessness. So that was very much the catalyst to this long-term career trajectory that I'm in now. So after that course, I thought I wanted to be a physical therapist. So health and human science major, study the body, and now I have this curiosity and excitement about homelessness, and I didn't know how to channel it or what to do. And so with Dr. Tarleton and some other peers, we started a research project on bridging my two passions, right? Homelessness and health. And so I started a project that was eventually published where we looked at the musculoskeletal health of young people experiencing homelessness compared to LMU students. And I could talk about that a little bit later, but it was my first publication. It was really exciting. I knew that I was on the right track, but still felt like I didn't have the tools yet to really enact change the way that I knew that I could, which is why the next step was to get a master's in public health. I just graduated from Yale, and so I live in New Haven right now, Connecticut. And there was where I met the people necessary to make DreamKit. DreamKit happen. So my co-founder, and I'll go to the team page in a little bit, my co-founder is a professor at the Yale School of Public Health. His name is Yusuf Ransom, and through him, I've been able to receive funding, we've gotten grants, to make DreamKit a reality. So basically, what DreamKit is, it has two main functions right now. So young people who download the app can get points, DreamKit points, for attending social services. So like going to case management meetings, going to workforce development programs, resume building workshops, parenting classes, clinical appointments. Basically all of the things that young people who are experiencing homelessness go to on a daily basis. We feel like at DreamKit you should be financially compensated for putting an effort and going to events that are gonna help benefit you professionally, socially, and help escalate you out of homelessness. And so therefore, with these DreamKit points that youth now have, they can use them like real money to meet basic needs. So to buy food, to buy clothes, hygiene products, haircuts for job interviews. And that is really based off of like Maslow's hierarchy of needs. That's someone who you should know if you're working with marginalized, at-risk populations, and he basically says, like, your basic needs need to be met in order for you to have this, like, higher executive function thinking, like applying for a job, applying for housing, getting your relationships right. And so with DreamKit, we're very much allowing youth to meet basic needs so they can free up some brain space and have that, like, higher function thinking. But I very much recognize that this points-based economy is a short-term solution to a systemic long-term problem, which is why we have the skills feature of DreamKit. So basically, each event that these youth are with their phones swiping into and checking into, each event is tagged with 3 different skill sets. So for example, if you like go to your case manager, you swipe in using DreamKit, the skills that will be loaded onto your profile are communication, time management, and problem solving. And so now your profile is a direct reflection of all the skills that you've been generating by going to events on DreamKit. And that's huge because from a data perspective, a technology perspective, we are not tracking the progress, the resiliency, the transformation of homeless populations. Like, we don't have a way to do that right now. And so with these DreamKit profiles, we're able to show and reflect someone's progress and skill set using the app and share them with people who can help. Share them with employers, share them with landlords, mentors in the community, to shed light on the resiliency that homeless populations are exhibiting. As a society, we do a very, very good job at tracking negative behaviors. Like, I can tell you someone's incarceration history, if they've been expelled or suspended in school, but I cannot tell you about their progress, which is a huge gap and it's a huge barrier, which is why we are really innovating in the space of finding the need in vulnerable populations and innovating solutions to help create that solution. And I'm here with you today as the founder, but I am absolutely nothing without my team. And so for any of you who are interested in entrepreneurship, using technology, especially in vulnerable populations, I cannot stress enough how important it is to have people with lived experience on your leadership team. As academics, we are trained to think that we have all the answers, and although we do have a lot of answers, we absolutely cannot create solutions that are sustainable, effective, respectful without people on our team who've actually gone through the problem. Which is why I've been very intentional in building my team to make sure that we have youth who have previously experienced homelessness. So they're called our youth specialists. So this is Yusuf, who I had mentioned. Aaron and Ashley are 2 young people who have experienced homelessness in New Haven, and now they are our main consultants for the project. We go to them for guidance, for new programs that we want to implement and getting their advice. In addition to, we have other students on our team doing research. It's crazy, you all. I graduated in the spring and now have this nonprofit company that's really looking at how to use technology for good in a very respectful way. So I want to give you guys just some lessons that I've learned, specifically in innovating in the space of tech entrepreneurship, which is Technology is great for marginalized populations for 3 reasons. Specifically that you can get instant feedback, and that process does not exist right now. So in boardrooms and in nonprofits, I've been a part of a lot of conversations with some heavy hitters who want to create these programs and solutions for homelessness, but they're not including the voices and lived experience of people who are actually going through it. And so DreamKit provides a way for service providers to send immediate text messages, immediate messages to folks to get their response, and then therefore include their recommendations, their advice immediately in the problem solving. But also, technology is great because every young person, at least that I've come in contact with, has a phone. That is not what a lot of lay people think, but it's absolutely the truth. Even if you are housing insecure, you're couch surfing, you're sleeping in an encampment, if you're a young person, like, you most likely have a phone. If not, there are federal programs from the Obama administration who have allowed people who are on like public benefits, so food stamps, Medicaid, to get free phones. And so if you want to create a solution, I highly suggest mobile applications because you're reaching an audience that absolutely can receive the program intervention that you're creating. But then lastly, because lay people have phones, marginalized, at-risk populations have phones, it's a great way to create pipelines of communications and understanding between the 2 organizations. And so the reason why we have these DreamKit profiles that we're sharing with landlords and employers and mentors, it's really valuable because we're allowing the pipeline of communication from this transient at-risk population of homeless youth to communities you can actually help. So if any of you are interested in entrepreneurship, creating a mobile app, I have 3 pieces of advice for you. And the first one, I touched on it before, but it's not about you. It's not about you, it's about the populations that you're working with. And so to really understand that you are, as a leader, as a founder, your responsibility is to create space for people who don't have it right now, to create platforms, to elevate the voices of marginalized populations. And so you cannot have pride in, too much pride in the work that you do because you are trying to elevate people around you, and it's really not about you. The second piece of advice is to show up. I cannot stress enough how much it matters to go to small events, big events, show your face, because especially working with homeless populations, there's a lot of distrust. There's distrust in like the man, there's distrust in the system, distrust in case managers, social workers. Like, a lot of the times, people are experiencing homelessness for a reason, and that's because they haven't been able to escalate out of that situation, and people who have proposed solutions to them in the past, it hasn't worked out. So you're coming in with this like new idea, and there's a lot of distrust. And so being able to show your face, show up, show you care, remember small things about people. Like my youth specialist, Aaron, he really likes these like cookie dough protein bars. So every time we meet, I'll bring him a cookie dough protein bar. And it's just building trust and showing up to the community so that you are basically portraying that you care in different ways, right? And then my last piece of advice is to crave failure. I cannot stress enough how many times I could have quit, how many times I felt very overwhelmed, but you need to crave failure in a way that your mindset is looking at failure as a way to grow, as a way to iterate, as a way to get a different approach or perspective on your idea. And if you can be excited about the times that you do fail, because that leads you to an opportunity to grow in a new way, like, you're absolutely going to be set. And entrepreneurship for vulnerable populations is absolutely for you. And so that's what I got for you all so far. I'm happy to answer any questions during the panel section. Thank you.
So now we'll invite all 3 speakers up, and we have some time for Q&A. I know there are several of you out there with questions because I assigned it for homework.
That's a great question. So Fun fact, we actually launched on Saturday, so it's very new. I've been working on DreamKit consistently for over a year now, and the reason why it took us a whole year to launch and to generate users is because of that trust building that I talked about. Yusuf and I had ideas about what DreamKit could look like in the future, but it took us consistently meeting with our youth specialists, going to libraries and getting focus groups going about what programs people want. So for example, down the road, we are going to include like a mentorship piece where youth can be paired with mentors in the community and invite them to events that they're going to. Use DreamKit kind of like Yelp, where they're rating the events that they're going to and sharing it that way. And so all these features that we have lined up down the road have come from conversations that we've had with youth with homeless lived experience. And so DreamKit right now, to answer your question, is in its infancy phase. And so we have, I don't know, a handful of users going through it, but the users that we do have, I've met by like going to youth shelters, going to like warming shelters. If any of you are from the East Coast, you know it gets super cold. And so they have these like temporary emergency shelters that people go to just to stay warm at night. So I've gone there and pitched DreamKit. And so all the users that we have on the app right now, let's say it's like 10, I've met face-to-face and showing up and making sure that although this is technology and it's maybe intimidating for people to engage with, making sure that they know there's a face behind the app that cares very, very deeply about this situation, population. Absolutely, yeah. So the question is, how do I get like events and programs on the app so that people can start receiving points and money for? And to answer your question, there in New Haven and on all urban spaces, there are specific events like case management, workforce development programs that happen regardless. We want to make sure that we're intentional in going beyond that and making sure youth know about so many other opportunities. So that looks like going to public libraries, going to like parks and asking people where have they gone within the last 7 days. It looks like sitting in at youth drop-in centers and just waiting for people to kind of have some downtime and asking them what have they been going to for the last couple of days. And then that looks like following up and going to those actual agencies, telling them about DreamKit, saying you can get youth paid for going to these events. Are you interested in making it as low barrier as possible? But it's a lot of grassroots work, and you have to be ready to just like get on a bus or get in your car and just canvass the city to make sure that everyone knows about DreamKit and feels comfortable putting their events on the app.
I have a question that was submitted for Professor Oppenheim. If you could sort of discuss or share your opinions on how systems engineering might address the access issue for marginalized populations in terms of access and financial burdens from this system.
Okay, it's a very difficult question. I have to be totally honest that the direct connection probably is not there. But the indirect is very powerful in the sense that healthcare systems engineering makes healthcare vastly more efficient and more cheaper to get simply. And that is a mechanism to draw those populations. If I may add a little bit to it, I think it's inevitable that we are going to end up with some kind of universal care in the United States. Everybody knows we are going that way. The political resistance from one party is huge, but it will be overcome. It shall be overcome. There is no doubt about it. The actual mechanism of doing it is still up in the open. My own preference is for going gently to reduce the resistance. In other words, the Medicare for all who want it. For all who want it. That's the proposition from two of the present presidential candidates. And once we capture those uninsured, and they will be satisfied with the government-provided healthcare, then it's inevitable that private companies will start dumping insurances. And those folks will be moving towards government systems. So sooner or later it's going to happen, and that, of course, will address those populations. And in terms of managing the universal care, in terms of the systems engineering management, yes, systems engineering is helpful in that. So indirectly, yes. Directly, probably not as a very quick direct link.
And then I have a question for Professor Freitas. There was an article in the Wall Street Journal, I think about 2 weeks ago, that spoke about how this issue of disidentifying data and how it's not really a reality. And so typically under HIPAA provisions and other provisions, a patient's personal identifying information is not supposed to be shared with third parties. However, there are some exceptions that are made if the third party can say that there's a need to share the data. So basically, recently, there are some hospitals that have been sharing patients' personal identifying data in order for data mining to happen for the sake of advancing science. And again, this is the whole for the sake of advancing science, which is subjective. Are there any ways in which computer scientists could help with this issue of disidentifying data, but also still ensuring that if identifying information is there, that there is a protection mechanism?
Thank you for this question. Yes. First of all, there's two options here. We can either try to balance innovation and privacy, or we can protect patient privacy because it's their right and innovate from there. So that's called privacy first software development. I don't know exactly in health what you would call it, but the things that computer scientists can do to help facilitate privacy first innovation are to develop like algorithms and data filtering mechanisms that allow you to learn about a population, not about individuals. There's ways of protecting privacy that are easier to do the more data that you have, because each individual would be less unique in that data set and therefore less likely to be re-identified. So the problem with HIPAA saying remove these identifiers, and actually there's like two options with HIPAA. You can either remove these 18 identifiers, name, birth date, social security number, phone number, etc., or you can have a privacy expert do your system for you. And the problem with option A, the de-identification, is that by combining other identifier or other information such as gender or age, so not birthday but age, zip code, these are very relevant to health outcomes, but in combination they are unique to individuals. So there was a study that said that 80% of people have a unique combination of, well, birthday, I don't remember if birthday is one of the things that has to be removed, but birthday, zip code, and gender. 80% of people, that would be unique to them. And once you remove those things, you get further away from like what you can understand about health anyway. And if you do share them, then you're making a statement that innovation is more important than individuals' privacy, which poses a safety threat. It's not a precedent we want to set, I don't think. And yeah, there's a lot going on there, but that's my initial thoughts, yeah.
And then could you explain what a privacy expert would do with, and what the mechanisms are in terms of ensuring that that person is acting in an ethical fashion?
Yeah, so bringing a privacy expert into data management processes would look like either they will take a data set and sanitize it in a way that doesn't involve removing entire columns in the data or entire points of information. So they're not just going to remove the gender column. They're going to kind of like fuzzy the data so that the conclusions you can make are still the same, but the individual can't be identified. So it's a little bit complicated, but the other option is that a privacy expert can set up a system where researchers can ask a specific question about the data set, and then the privacy mechanism decides whether or not that's going to leak information. And then from there, it'll either answer the question or modify the results or say, I can't answer that, something like that. Yeah, thanks.
Other audience questions? Perhaps, yes. Yeah. So the question is about regarding the upcoming election and candidates addressing their concerns about healthcare and technology. So the question is for all panelists to comment on what some of their priorities or concerns might be with that regard. We'll start with Marina and then go down.
Oh my God, that's a really good question. I'm really curious what solutions look like that are involving people with lived experience at the forefront, kind of what I chatted about before. And so in future elections or policies that are being made, being really, really intentional of how we're spending government money to make sure that it's not just perpetuating systems that aren't working and that are broken. And I think an entry point in is entrepreneurship, and an entry point in is elevating people's lived experience, because that's truly how we're going to make sustainable solutions. So I just would love more federal dollars being funded towards like youth advisory boards and focus groups and tech-based solutions for homelessness, because I've seen a lot of progress within the past year, right? Like I just graduated with my master's in public health, and now I founded a nonprofit. And that's really because people believe in it, and the rapidness that I've been able to experience success is because of my leadership team and it being very effective, because they've experienced the problem. So.
I'll do this. I would second that. I hope that whatever comes out of whatever evolves is based on lived experience. In my opinion, a lot of the problems that we all talked about with healthcare and technology are rooted in a corporate greed that is like intimately connected with the healthcare system because of private insurance and because of, right now what we have is like medicine for profit. That's like the system that we live and work in. And so in my opinion, a single payer healthcare system will remove those disaligned like values of we're building these like EHRs for billing because it's complicated, whereas a single payer is more simple billing wise. It also takes away a lot of the opportunities for the technology that's being developed to be exploited by these corporate interests. Yeah.
I basically second the previous speakers, what they said. Let me add the following specific number. In US healthcare, we waste 50 cents of every dollar on insurances, both on the insurance side and on the provider side that need to haggle with insurances. There are huge bureaucracies in every hospital, in every clinic fighting. If I may go sarcastic for a moment, the way it looks, it's this. A hospital sends a bill to the insurance, charging $500 for a pill of aspirin and $20,000 for a night pot. And the insurance, of course, rejects that and says we'll pay only 5 cents for the aspirin and so on. And then the hospital haggles again, sends the demand to pay again. And they keep haggling, and each side has tremendous bureaucracies doing it. And altogether, that cost consumes 50 cents of every dollar. In other words, if we could eliminate completely that system and go the way the other countries do, we would have immediately twice the budget that we presently have for treating patients. So that's a dramatic number. In terms of practical implementation of the single-payer system, given the present politics and the divisions that we have in this country, I don't believe that the approach by Sanders or Warren will be successful, because the other side will immediately start propagandizing them as socialist, communists, and so on. The American public does not understand the difference between social democracy, socialism, and communism. To an average guy, it's all kind of horrible, red scare. So given that situation, we have to go gently, and I believe the only practical way to do it is what Pete Buttigieg and Senator Klobuchar, that's how you pronounce the name, right? I always have a problem with that, promote, and that's, again, Medicare for all who need it. So let's capture immediately the uninsured. That can be done very fast with only one act and at a relatively modest expense. And then during the next 5-10 years, the system will inevitably migrate towards a single-payer system, because the private companies such as LMU, LMU provides a very nice medical insurance to us employees. So such companies will be slowly dumping the insurance option from their benefits, and those people will be moving to the single-payer system. So I think that's a more practical approach. But whatever we do, the accusation of being communist and socialist will be made, and we have to fight it. And it's up to you folks, to argue with whomever to help with that. Thank you.
Okay, well, I'll pose one that was submitted. This is sort of a last question about access and about the use of digital doctor's visits. And for each of you, do you feel as if the increased reliance on digital doctor's visits, or communicating, taking pictures of things or communicating with doctors electronically, is that promoting access in terms of access to care, or is that introducing a disparity where individuals who can't make it to see a doctor might be receiving less quality or lower quality health care, or less attention in terms of efficiency and efficacy? So I will start with Dr. Oppenheim and then come down.
Thank you. Great question. For routine visits, absolutely. It's a great benefit. Somebody with a flu doesn't need to go to a clinic and spread the bug among everybody in the waiting room and all the stuff. So absolutely, it's already working. It can work quite well. For very complex cases, obviously not. A personal visit is needed. There is a whole bunch of medical conditions that require this touch of the doctor, the physical touch on the body of the patient. For those, we still need clinics. But we live in Los Angeles. We all know the traffic here. Who likes taking off from work or from school for half a day to drag oneself to a Kaiser Permanente or UCLA and park, looking for parking, and then marching a long distance to the clinic, and then waiting in the waiting room, blah, 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 the routine. So it's all a very unpleasant, unnecessary experience. If we can do it in 10 minutes, sitting in front of our computer, and if it can be done, let's do it. The doctors should be the final judges if a follow-up personal visit is indeed needed or not. It should not be the final decision should not be the patient's, should belong to the doctor. And there will be a class of visits requiring personal visit, face-to-face, and all the others can be done quite well by electronically.
Thanks. I totally agree. I liked the point you made in your talk that doctor's visit is 15 minutes, regardless of whether we're updating a prescription or getting a prescription refilled, or we're being explained our cancer prognosis, right? Those are the same 15-minute visits. So absolutely, there's an opportunity to lighten the burden of simple, easy, straightforward tasks in medicine, and those do exist. But I would just add that that's not going to happen automatically. Deciding these are simple and can be automated, or these are complicated and deserve more human attention. I don't think that'll happen automatically. There was already a project automating sharing the news of getting a cancer diagnosis. So people are already kind of doing it wrong. So I think it's something to pay attention to. And then I would also just add, I work on a project that involves labeling medical data. So you can't make the machine learning algorithms unless you have labeled data. So there's a ton of the certain kind of like brain data that we have, and we can't use it because it's not labeled, and it requires a human to circle like this signal in this data means something. So we're trying to automate the simplest pattern recognitions so that the humans can like identify more subtle things. And I always kind of reference that as an opportunity versus what we don't want to do is displace these healthcare workers in a way that harms patients ultimately.
And from a patient's perspective, specifically those who are experiencing poverty, there are a lot of barriers to even physically get yourself to a hospital or to a doctor's appointment. That looks like bus routes, if your bus didn't make it, or if you have competing priorities, right? Like if there's a soup kitchen open and you'd rather get lunch than go to the doctor's office, like you're gonna pick lunch. And so in understanding the plethora of competing priorities and barriers that exist of just even getting yourself to a doctor's office, I think that there's really interesting and exciting ways that you can introduce technology and have doctors' opinions being sent to you through a mobile phone or a technology computer, whatever of the sort. And especially when you're looking at homeless populations, the mental isolation and learned helplessness that is very apparent in people experiencing homelessness is frustrating. And when you can introduce technology and say, there's a doctor on the other line waiting to give you a diagnosis or to learn about what you're going through, that gives someone a glimpse of hope to say, all right, someone cares about me, even if, right, I haven't talked to anyone all day, I haven't made eye contact with anyone all day, I feel very, very isolated in my homeless experience. The technology gives us an opportunity to say other people are thinking about you, other people are caring about you, even if they're not physically in front of you, which can do such a whole host of benefits that we also need to like quantify and measure and evaluate in order to promote more of these types of interventions that use technology to access like transient at-risk populations.
So I want to thank all of our panelists for sharing their time with us today. Thank you all for coming. And I'd just like to add that on this panel, we have individuals from the systems engineering perspective, computer scientists who works kind of in the system, building the system, and then a public health practitioner who's working with communities and individuals. So please take the opportunity, if you have a few minutes, to say hi to them, meet them, ask them questions about their field, their expertise, because they do represent the full spectrum of individuals who will be helping us as a community to solve these problems. Thank you.